cute. Good morning, everyone. Welcome to Implementing Trauma-Informed Care on Labor and Delivery, a case-based approach with our speaker, Dr. Alyssa Conklin. My name is Kara Berg-Ronick. I am the Director of Health Strategy and Advancement at HCET, as well as the Director of the Midwest Trauma-Informed Training Center, and I'll be moderating the webinar today. I want to briefly introduce you to HCET, or Healthcare Education and Training. Our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. We're an organization of passionate people who are proactive in our belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. Next slide, please. So this webinar has closed captions available. To enable them on your screen, click Show Captions at the bottom of your screen. Next slide. Thank you. To submit a question, select the Q&A icon at the bottom. Please send all your questions through the Q&A feature. This helps me make sure that no questions are missed and that everyone in the webinar can view your question. You can also send them anonymously if you'd prefer. We'll try to hold questions till the end. So there's also the chat feature available, and at a few points throughout the presentation, Dr. Conklin will ask for your input or kind of interaction, and that's when you can use the chat feature. But again, for questions, please use the Q&A feature. Nursing contact hours are available for this webinar, and just follow these instructions. You'll also get this in an email afterwards. So you'll have to stay for the whole thing, return your post-test evaluation, just evaluation, no post-test, no worries. And then you'll send this contact form to Kelly Bradford. Please feel free to follow us on our various social media accounts. That's one of the best ways to stay up to date with information and events. And Dr. Conklin will also share a QR code at the end of the event to stay up to date on the Midwest Trauma-Informed Training Center. Again, a link to the evaluation will be put in the chat at the end of the webinar, and you'll also receive it via email. Please do complete that. We look at them very seriously so that we can provide the best future presentations possible to you. It'll take less than 5 minutes to fill out, no big deal. All of our archived presentations and upcoming events can be viewed on our website. And if you do have any technical difficulties during the website, please contact updates@hcet.org, and that will be being monitored throughout the presentation. Almost lastly, no one with the ability to control content of this activity has relevant financial relationships to disclose. And then lastly, I want to tell you a little bit more about the Midwest Trauma-Informed Training Center. So MTITC has a goal to transform the landscape of health and human services by equipping professionals with the knowledge, skills, and support to make TIC standard practice for all. So we provide in-person and virtual trainings, resources, and technical assistance in trauma-informed care for free, available to healthcare providers across the Midwest and across the country. It is now my absolute pleasure to introduce my friend and colleague, Dr. Alyssa Conklin, and she will tell you a little bit more about herself.
Thank you, Kara, for that. So hi, everyone. I am Alyssa Conklin. I'm one of the general OBGYN faculty at Indiana University. I also side gig as a content expert on trauma-informed care with healthcare education and training, along with the Midwest Trauma-Informed Training Center that she mentioned. And I'm happy to share this content with you today. This is a little about me and what I do. I've been on faculty at Indiana University for 4 years now. And prior to that, I was in private practice in Michigan for about 9 years. I am passionate about trauma-informed care, including what some call the gentle or family-centered C-section, which we'll actually get to in one of our cases today. I've been cultivating my practice on trauma-informed care for more than 10 years. In this space, I do that consulting work for HCET and the Midwest Trauma-Informed Training Center. And I also do statewide work through IPQUIC, the Indiana Perinatal Quality Improvement Collaborative, which is a statewide collaborative aimed at reducing maternal morbidity and mortality throughout our state. And through that, I serve as the chair of the Women's Health Task Force. These are the objectives for our talk today. Before we can understand how to practice trauma-informed care on labor and delivery, we first need to really understand what trauma is, what defines trauma, what does trauma-informed care mean, and recognize the benefits of this type of care, and then we can dive into how you can apply that on labor and delivery. This will be our guide throughout this talk, and we will begin with what defines trauma. Now, before I begin on this background, I just want to mention that if you have attended any of my HCET webinars before, these first few slides will be very familiar to you. I think it is so crucial to understand why trauma-informed care is so important for everyone. And the only way to start that is to understand what trauma really means and how trauma-informed care is a different approach to medicine. So I think a refresher is always wise, but also there are some new folks here today who've probably never heard this information before. So let's begin. Trauma can be defined in many ways. It's not just what most people think of when they think of trauma, like a traumatic car accident, an injury, or a sexual assault. The Substance Abuse and Mental Health Services Administration, or SAMHSA, defines it as something that results from an event or set of circumstances that's experienced by an individual as physically or emotionally harmful or even life-threatening, and that has lasting effects on the individual's functioning and well-being. Notice those 3 E's of events, experience, and effects. So looking at those 3 E's of events, experience, and effects, experience is the key. It's the individual person who decides if a given experience is traumatic or not. And the same event that can be experienced by one person as traumatic may be just the opposite to another. A great example in my world of obstetrics is a C-section. One person may truly prefer this type of delivery and feel empowered in that decision. Another person may find a C-section to be one of the most traumatically impactful experiences of their lives, perceived as a failure of their body or their goals or their self-image, and they could be reactivated or reminded of that trauma every time they look in the mirror at their own body or every time they come into their obstetrician's office. Types of trauma can be broken down further into additional categories. Some trauma is acute, like a one-time event like a sexual assault, and some is chronic or complex, like witnessing or experiencing domestic violence, loving someone with a substance use disorder, or living unhoused. And I want to spend just a few minutes on another type of trauma, historical trauma. Historical trauma reflects systemic oppression of a particular group across generations and disproportionately affects people of color. This could include genocide, slavery, police brutality, or forced relocation, among many others. Our patients often bring well-earned historical mistrust of the healthcare system into our interactions with them. And it's important to recognize this because this will be the lens through which our patients impacted by historical trauma will view us in healthcare. For context, I'll share some very well-known examples of this in gynecology. We'll start with J. Marion Sims. He was considered the father of gynecology and even had a statue erected in his honor in New York City, which has since been removed. Sims invented the speculum, but he did this by experimenting on enslaved Black women. He also developed multiple surgical techniques. You may have seen this painting before and just didn't know what it was. This is Dr. Sims in Antarctica. She was an enslaved Black woman who was just 17 years old when she had her first baby. And Dr. Sims performed 30 non-consensual surgeries on her, and he did that without anesthesia, even though it had recently become available at the time. Back then, it was believed that Black women did not feel pain as much as white women, and in fact, that myth still persists today. It's well documented in the literature even now that Black people receive statistically less pain medication than white people do during hospitalizations and after surgeries. This legacy of violence and historical and intergenerational trauma continues in our society, with more examples than we can count, from Henrietta Lacks, a Black woman who had her cells taken during cancer treatment in the 1950s without her knowledge or consent or compensation for use in medical research, which created the famous HeLa cell line that we use even today for all kinds of medical breakthroughs. Or the history of the pill, where clinical trials were done in the 1950s on Puerto Rican women without being told they were in a trial or about any of the risks involved, to our country's history of coerced and involuntary sterilization, which was rampant even into the 1970s, to the Tuskegee experiments, where Black men were followed for 40 years from 1932 to 1972 without treatment to see the progression of syphilis without their consent, well after treatment for syphilis was available. There are people alive today who have either experienced these atrocities themselves or their children who grew up hearing about it. All of this has sown distrust in our system and in us. Systems-level trauma and historical trauma enter our encounters every day in healthcare and in real life. Keep these historical atrocities in mind as we move forward in this talk. So now that we have an understanding of the vast experiences that define trauma, let's look at something known as adverse childhood experiences, or ACEs, and the impact that those can have on healthcare. Hopefully you've heard of the adverse childhood experience, or ACE, study, But if not, here's a quick introduction because this is truly the foundation for why trauma-informed care even exists. ACEs are traumatic events that occur in childhood before age 18. In 1998, Kaiser Permanente, along with the CDC, did a landmark study looking at 10 categories of childhood adversity that have been found to be particularly impactful on long-term health. This study found that these experiences linked to a cascade of adverse health outcomes, and the more categories of ACEs a child experiences, the more likely they are to experience bad health outcomes later in life. The participants in the study were largely white, largely middle class, and highly educated. So a second study was done around 2015 in Philadelphia that focused on an urban and more diverse population and focused on community level adversity and how those could impact health outcomes, and ultimately found these 5 additional ACEs noted here in the dark blue circles: living in foster care, feeling discriminated against, experiencing bullying, witnessing violence, and experiencing adverse neighborhood events. ACEs are incredibly common. From the original 10, 64% have at least one ACE, and 17% have 4 or more. So with that in mind, what impact can ACEs have on someone's lifetime? Well, the more ACEs a person has experienced, the more likely they are to have any of these negative health outcomes. For example, people who've experienced 4 or more ACEs are 12 times more likely to have attempted suicide, 7 times more likely to abuse alcohol, 10 times more likely to have injected street drugs, and US military veterans with a history of ACEs have a significantly higher likelihood of developing combat-related PTSD compared to veterans without ACEs. Also, the CDC states that at least 6% of all cancers could be prevented if children did not experience ACEs. In Indiana, nearly half of Hoosier children have experienced at least one ACE. In fact, Hoosier youth have a higher prevalence than their peers nationally, in 8 out of 10 ACEs, as measured by the National Survey of Children's Health. Also, 3 of the top causes of pregnancy-associated deaths are linked to higher ACE scores, including accidental overdose, which was the #1 cause of pregnancy-associated deaths in 2023, which is the most recent year for which we have those data. Keep in mind that 1 in 8 people has an ACE score of 4 or more. So it's almost guaranteed that we are all interacting with people every single day who have experienced significant trauma in their life. Okay, so now that we have a good foundation of what trauma is, what ACEs are, and the impact that those can have on our health, let's talk about what trauma-informed care is. Trauma-informed care is a whole person approach to healthcare that acknowledges the impact of trauma on health and is inherently patient-centered. A trauma-informed framework assumes that everyone has a trauma history and that medical evaluations and treatments themselves are potentially traumatizing. It acknowledges that a patient's life experiences will impact their perspectives when engaging in the healthcare system, and that awareness of these perspectives has the potential to improve patient engagement, treatment adherence, and health outcomes. Trauma-informed care is not the same as providing medical trauma services, such as treating a broken leg, and it's not intensive therapy for trauma. Rather, the foundation of trauma-informed care is the assumption that all people carry past traumas and that all people benefit from this type of patient-centered approach. And importantly, disclosure of someone's past traumas is not necessary to provide trauma-informed care. This is called the universal precautions model. It's like donning our gloves before we examine a patient. Why do we wear gloves? We assume anyone could have a bloodborne illness, right? And that assumption has become so consistently a part of our care that we don't even think about it consciously. We just put on our gloves. Trauma-informed care should be applied with the same universal precautions model. Assume everyone has a history of trauma and you'll never go wrong. You'll put those proverbial gloves on for every patient and approach every patient with a trauma-informed lens. We utilize the 4 R's created by the Substance Abuse and Mental Health Service Administration, which states that a trauma-informed approach is one that realizes the widespread impact of trauma, recognizes the signs and symptoms of trauma in clients, families, and staff, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. This 3-minute video is a great introduction to trauma-informed care and the impact that those ACEs can have on a person's lifetime, as well as a brief overview of what we can all do to implement a trauma-informed care approach. It introduces what is really the greatest take-home message of trauma-informed care. It's a key paradigm shift, shifting your mind from what is wrong with you to what happened to you, moving from a place of judgment or frustration to one of curiosity and empathy.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made, plus our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Okay, so now that we have some background on trauma and ACEs, as well as a basic foundation for what trauma-informed care is, let's dive into some cases on labor and delivery. So we'll start with a patient who's 19 years old, African-American woman presenting in labor at 38 weeks with her first baby. You review her history. She has no medical problems. She's had no surgeries. This is her first baby. She denies any history of sexually transmitted infections. Her partner is with her and supportive, and she is currently living unhoused. And her mom has ongoing struggles with substance use. So you have her history. What are the clues in her story that might point to any ACEs? For reference, here are those 15 known ACEs. And in case you have a keyboard in front of you, which most probably do, this is the audience participation part. You can feel free to type in the chat any clues in her history that I've listed there that you see might point to any adverse childhood experiences using those 15 known ACEs as a reference. And I don't see any typing. I don't know if anybody else can see. Unhoused, yep, history of substance abuse in her mom, agreed. Substance abuse history, got it. We know for sure she has that history of substance abuse. There we go. Her parents are not together. Also, she's Black, so she has likely been subject to racism in her life. But as with most people, we simply do not know what other ACEs she may have experienced, right? Was she ever in foster care? Any history of abuse? Her mother struggles with that substance use. Is that related to any underlying mental illness as a form of self-treatment? Has anyone in her family been incarcerated? What about neighborhood safety? You just don't know, right? Now, what clues may point to a trauma history? Let's review. She's a pregnant teen. Her partner appears supportive, but we do not know if this conception was consensual or not. She's living in a shelter. It turns out she was living with her mom, who was using substances around her. And when her mom was using substances, she would get verbally and physically abusive to our patient, so she moved into a shelter on her own. She just got a job at a restaurant where she met her current partner. She actually conceived through sexual coercion because she was staying at a friend's house when she first left her mom, and her friend's boyfriend sexually assaulted her. She wants to keep the baby. Her current boyfriend knows her history and is supportive of her and intends to raise this child with her. He just got a job as well, and they are saving to get an apartment. You would only know this if you ask and if she was willing to reveal this. That is why the universal precautions model for trauma-informed care is so important. You really have no idea what is hidden under the surface when you're interacting with patients. So when it comes to admitting someone to the hospital, how do you go about that admission conversation? Do you do this in front of others in the room? Excuse me, do you ask them to leave? Do you ask the patient what they would prefer? While the latter may seem the most altruistic and giving the most power back to the patient, if there's an abuser in the room, the patient will rarely say they want them to leave, and this is because a request like that would likely be a source of retaliation from the abuser at a later time. Be intentional about how you're doing this and who is around and what you're saying. What do you do when you see or hear a red flag? There are many ways to address this, and some may be actually ineffective or even harmful, like asking about abuse or if the pregnancy was conceived consensually in front of others. But there are two important points when gathering a patient's history. One is to be intentional about how, when, and around whom you gather this information. And two is to be both on the lookout for any concerning history points that may put this patient at risk, and also to have an intentional plan to address them. In our hospitals, we often call social work when a red flag pops up, and we'll get to that in a bit. So our 19-year-old, she had her baby, the delivery went well, and she is now over the moon happy snuggling her newborn. The next day, someone knocks on her hospital room. It is a social worker. She introduces herself, and while she begins telling this patient why she's here, the patient internally is freaking out because unknown to anyone else is that she did in fact spend a few years in the foster system as a child while her mom was incarcerated for issues related to her substance use. She has trauma related to this and associates social workers with that trauma. So she's feeling fully activated or triggered right now. So while she's internally panicking and activated from her past traumas, she finds enough strength to ask the social worker why she's here. The social worker tells her she was consulted because this patient's urine drug screen on admission was positive for opiates. But here's the first thing. She never consented to this test. In 2001, the Supreme Court ruled that healthcare professionals cannot get a urine drug screen from a pregnant person without their consent. 29 of the 30 women who filed this case were Black. Black women are statistically far more likely to get a urine drug screen on admission to labor and delivery than white women. Many hospitals in this country do not have policies regarding urine drug screens. Ordering them is left up to the provider. The lack of these policies continues to widen the gap on disparities in healthcare and fuels implicit bias and, quite frankly, overt racism, and is yet another example of policing Black and brown bodies when these medical tests are weaponized against patients. Thankfully, where I work at Riley and Eskenazi, we do have protocols about when urine drug screens are ordered, but that's not true everywhere. So if you're in a hospital or institution where there is no standard policy regarding urine drug screens, consider doing that. Consider creating one. The other interesting point here, which will go ignored in the dominoes effect that will occur to this woman because of this unconsented drug test, is the fact that she actually doesn't use drugs. She actually had cravings in this pregnancy for everything bagels. They're very good. Well, this patient binge ate 5 to 6 of these in the last 2 days, and it turns out that is why her urine drug screen is positive for opiates. Did you know that's possible? It's the poppy seeds in this mix that's the culprit. But guess what? The hospital, while technically illegal in urine drug screening this patient without consent, does have a policy that once a urine drug screen is positive, social work must get involved along with CPS. Can you imagine how traumatizing this is for this patient? And this story of an everything bagel seasoning obsessed pregnant patient with a urine drug screen positive for opiates is a real story, and it was published in Newsweek just last year. And it's not just poppy seeds. There are many prescription and over-the-counter meds and even foods that can cause a false positive drug screen, as you can see here. And this list is by no means exhaustive. I'll just focus on a few of the most commonly encountered ones in obstetrics. It's crazy, right? So how can a social worker and us, would we round on her the next day with all this going on, practice trauma-informed care in this setting? The first step is gentle introduction and non-judgmental probing. If you use the universal precautions model that trauma-informed care is based on, you will assume this patient likely has a history of trauma. Also pay attention to your approach and stance. Are you standing? Do you sit? Think about the power dynamics communicated through how you position yourself, as you can see in these pictures. Trust and transparency are key to trauma-informed care. Kindness and conversation without judgment are absolutely key to building trust. Are you able to listen to this patient without bias or any preconceived notions when she tells you she doesn't use drugs? So now we'll move on to our next case, which is practicing trauma-informed care during a vaginal delivery. This patient is a 31-year-old presenting in labor at 40 weeks with her second baby. You review her history. She has no medical problems. Her only prior surgery was a C-section 5 years ago. The C-section in 2020 was for fetal bradycardia and it was emergent. She had chlamydia 5 or 6 years ago and denies any abnormal pap smears. She's married, she feels safe in her relationship, and she denies smoking, alcohol intake, or illicit drug use. And her family history is non-contributory. So you have her history. What are the clues in her story that might point to any ACEs? Again, here are those 15 known ACEs. And I'll just dive in and say, with her history listed here, there really doesn't appear to be that many ACEs, right? We have no idea if there was substance abuse in the family when she was growing up, or if her parents are not together, or if there was any abuse in the family. We have no idea if she grew up in foster care or felt safe in her neighborhood. We don't know if she was bullied as a child or if she witnessed anything violent in her community. So what clues may point to trauma? Let's review. She had that unplanned emergent C-section with her last baby due to fetal bradycardia. And I don't care how strong of a person you are, that is some scary stuff to go through. It turns out she was terrified. Her bag of water broke. All of a sudden, the baby's heart rate dropped. The doctor rushed in and put a fetal scalp electrode on, and the baby was in the 60s. They tried all the things that we normally do, but didn't work, and they were consenting her for the C-section as they were running to the operating room. When they put her on the table to give her general anesthesia, she couldn't hear the heartbeat anymore of her baby. And she remembers everyone was running around saying stat, and then she was knocked out. When she woke up, she kept trying to ask if her baby was alive, but she couldn't get the words to come out of her mouth. And no one told her for what felt to her like hours. Her greatest fear is that this will happen again during this labor. Also, she was sexually abused before she met this partner, and you don't know that, of course, unless you explicitly ask, and only if the patient's willing to disclose this, but that's how she got chlamydia. That is why the universal precautions model is so important, like how we put those gloves on to examine every patient. Assuming every patient has a history of some kind of trauma makes it easy to treat everyone with a trauma-informed approach. As we all know, when someone is in labor, at some point, it's highly likely their cervix will be examined. As you can see in this model here, by its very nature, it is intimate and a potential source for trauma and reactivation of traumatic experiences. And to even get this exam done, the patient has to separate their legs and allow us into their very vulnerable and often very exposed space. Here is a picture of a laboring woman having her cervix examined. And do you see in this picture how the examiner is also holding her leg? How activating do you think that that could be? What if she had a history of sexual assault before? Do you see all the vulnerabilities here? Discussing with the patient why you recommend a cervical exam at this time and exactly how that will be performed, and also trying to be mindful of what you can cover up and what actually needs to be exposed helps every patient feel more at ease and less vulnerable during these exams. Also paying attention to your stance, again, with this patient. Are you sitting on their bed? Are you standing next to them? Are you sitting in a chair besides their bed? All of these convey different power dynamics. Sometimes certain places or positions for us are necessary, but just be mindful of how your position is being perceived by the patient. And when it comes to the actual delivery, how is that done? As you know, the nurse often pushes with the patient for a while before the delivering provider gets called in. But then as the patient is getting close to delivery, many people come into the room beyond the labor nurse and the delivering provider. There may be 2 residents, an attending, 1 or 2 medical students if you're at an academic institution, not to mention the peds team for the baby. All of the folks in the room have a role, but it easily happens without explaining or asking the patient if it's okay to have so many people in the room. And this brings up the very important point of consent. Consent is something that should be unmistakable, often verbal, uncoerced, freely given, reversible at any time, specific to the situation, and informed. We have to honor that this patient is welcoming us into their space. It's not the other way around. We need to be mindful of this and explain who everyone in the room is and why they're here. Also, when learners are in the room, we really should be asking the patient if that is okay and not assuming that the patient consents. Here's a picture of me delivering my first child, and the delivering person is very much all up in my business, as we know is always the case during deliveries. It all looks good and fine, right? But in fact, during this delivery, she cut an episiotomy without a discussion or my consent, even though there was no medical indication. I pushed him out in under 20 minutes, and you can see the fetal monitoring in the upper left corner of the picture, which is a category 1, so there was no urgency. This happened to me after I was already a practicing OBGYN with a lot of knowledge and privilege. Now, it's important for you to remember that most patients do not have this knowledge, and many patients don't feel like they have a voice. And that's not necessarily any fault of ours, but remember, patients often come into our space with those past traumas and experiences that make them feel this way. And that doesn't mean there's nothing we can do about it. And that's why it's so important for us to create a space for them, a space where they feel safe to speak up and that their voice matters. All right, moving on to our next case, managing a postpartum hemorrhage in a trauma-informed way. For this case, we'll stick with our 31-year-old patient who just had a successful VBAC, a vaginal birth after C-section, and she's super happy about it. Here is her history as a reminder. I did not have a VBAC, but it's hard to get birth photos with consent, so here's a picture of me right after having my second son for visual effect. So the birth went great, everyone is thrilled, the patient seems so happy and so relieved, and then she starts to bleed heavily. And you know what I mean, the kind that goes from this to this pretty quickly. How do you manage a postpartum hemorrhage in a trauma-informed way? First, we have to acknowledge that this is an emergency. So of course we can't take a bunch of time to address this. However, these type of emergencies make it really easy to not perform trauma-informed care, which is why it's so important to talk about it. What do we normally do here to manage this? Usually there's fundal massage, likely a manual intrauterine sweep if the fundal massage doesn't stop it, then various medications, maybe even a device like a Jada or Bakri. It's so easy for us to just jam an arm up in their uterus without actually talking to the patient. And while yes, this is an emergency, the first step is to pause, inform the patient what is going on, and tell them what you need to do and why. So before you touch this patient to manage her hemorrhage, you might say something like, "You're bleeding heavier than you should be right now, and to stop this, we're going to need to do some things. One of them is to press hard on your belly to see if that stops your bleeding." And then do that. And if that doesn't stop the bleeding, you can say, "That didn't slow the bleeding down, so next I need to put my hand and arm into your vagina and into your uterus to get out the clots." We'll start first just in the vagina and cervix, which will feel like a lot like having your cervix checked in labor. But if that doesn't slow it down, we're gonna have to go all the way up into your uterus. It's going to be a ton of pressure, and I can pause or stop at any time, but it's very important we get this bleeding to stop, and it takes about 1 to 2 minutes. Is that okay? And I know it seems silly to ask them if they're okay with us helping them not die, but how we help them is the key here. We are in this together with the patient, right? You want them to feel like we are doing things with them and not just to them. I have never had a patient tell me, no, it's not okay. I have had patients say, just give me a second. And even though the bleeding is happening, you can wait a minute, 2 minutes, whatever they need to just get a moment and be ready. This approach, informing them and making sure you have that verbal consent, goes so far with that patient feeling empowered by consenting to this thing that is going to hurt and knowledge and the urgency and importance of this. So you do all those things, including placing the Jada device. And because you are so great with trauma-informed care, prior to placing the Jada, you explained again exactly what you want to do and why, and what the patient can expect and feel. And you got that verbal consent from the patient that it's okay to proceed. Now that the delivery is over and the hemorrhage is managed, what do you do now? This only takes a minute or two, but one of the most informative and empowering things you can do after any delivery, but especially after delivery that didn't go quite as expected, is to debrief with the patient. Again, this may seem silly, but there are a ton of resources out there, including apps, books, and even podcasts for patients who feel that they never really got a debrief after their delivery, and they're left feeling like we didn't care about them. For example, I can't tell you how many times I have heard a patient tell me about their prior birth, and they've said to me, "I bled so much I almost died." And then when I asked them if they receive a blood transfusion, they said no. Well, there's clearly a misinterpretation here, right? You're not going to be close to dying without a blood transfusion. Taking a quick moment to explain to the patient what happened and what was done is so meaningful to them. This is true even with normal deliveries. Maybe it will help prevent those patients who think they hemorrhaged almost to death but never received a blood transfusion to realize their delivery was actually normal, their blood loss was normal. And then for that hemorrhage patient, take the time to tell them everything that happened and what the plan is going forward. When will you check on them again? When will that device come out? How often are they going to get their blood drawn? It helps them process everything in a way that creates less trauma for them going forward. All right, moving on to our last case of the day, a non-emergent C-section. This patient is a 40-year-old G7 P5015 presenting for her scheduled repeat C-section. She's had 5 prior sections and she's always had a blue drape and the baby has always been taken to the warmer first. In fact, she's never been able to hold her baby until she gets to the recovery room. She doesn't tell you this, but she has always felt her birth experiences were made for her. She doesn't feel like she has a choice with her births, and it's something that makes her sad and is also a bit re-traumatizing every time she has a delivery. What can you do for her to resist that re-traumatization and maybe even help her heal some of that trauma? You can offer birth choices. Traditionally, like we're all used to, the patient gets that blue drape, they can't see us or anything going on behind the drape, and they certainly can't see their birth. The baby goes straight to the warmer and not with the birthing person, and they often don't get skin to skin until they get into recovery. Maybe the patient will be shown their baby by the peds team like this, or maybe the baby is never brought to the patient and they're left either straining to try to get a look or can't see their baby at all if the warmer is on the opposite side of the OR like this. So what birth choices can we offer in the operating room? Well, first, drape options. Do they want a blue drape where they don't see anything or a clear drape where they can see everything? The cost between the 2 drapes is the same. Do they want to watch the birth? And that's easy if they have the clear drape, but if they have the blue drape, you actually can drop the drape so they can see the birth. When you deliver the baby, do they want the baby put in the warmer first for assessment, or would they actually want the baby delivered up to their chest? If they choose up to the chest, I discuss with them there may be reasons we can't do that, and sometimes even after the baby goes up to their chest, the NICU or the peds team needs to take the baby to the warmer, so I make sure that they know that's a possibility. Does the partner want to do skin to skin? If yes, they need to go to the OR shirtless under that white suit that ours is white. Do they want to play music in the OR? If they do, I ask them to get an hour or an hour and a half of music together. At one of our delivering hospitals downtown Raleigh, we have speakers in the operating room and the patient can actually Bluetooth their phone to them. At our other hospital, Eskenazi, we don't have those speakers in the operating room, but we really could easily buy one of those mobile Bluetoothable speakers and everyone could do that. They're cheap. Or the patient could just play the music on their phone if they want. Also, I try really hard to keep the conversation in the room about the patient and their family. This is really difficult because phones are ringing and other patient care is going on, but just try really hard to be mindful about this and avoid it when it's not absolutely necessary. So how do you really operationalize this? If patients want drape choices, whether or not they want the baby delivered up to their chest, it takes a little bit from every team, so let me explain. For OB, if you're the delivering provider, you wear a set of surgical sleeves and have a 3rd set of gloves available. I discuss with NICU before the section that this is the plan, and I ask NICU team to give me a visual yes or a visual no about the baby going up to the chest once they're delivered. Anesthesia has to drop the drape, so after they drop the drape, I pull down the birthing person's gown a bit, and I get the baby situated on their chest with them. And then I tuck my hands under the gown, I lift the gown and drape up over the baby, and then I back away. I remove those outer sleeves and that outer glove. And then I put on new gloves. We then clamp the cord down in the sterile field and sort of toss it over the drape. Anesthesia's part is to drop the drape like I mentioned, and ideally elevate the head of the birthing person a little bit so they can see a little bit better. And then after the cord is cut, they replace the drape back up. NICU's role is to give us that visual yes or no at the delivery, and then someone from NICU typically goes to the head of the bed to assess the baby on the birthing person's chest for the first few minutes. After I change my gloves, and usually around when we clamp and cut the cord and put the drape back up, I then ask everyone in the room to sing happy birthday. I know it seems silly, but most patients actually love this. It's also something I discuss with them in advance, and I can't tell you how many patients have cried in my office when we are discussing these options about how wonderful it feels to have these choices and to hear happy birthday in the OR. Most patients love having skin to skin in the OR, and it's really not that hard to operate around the baby. Here, I'm going to spam you with a bunch of pictures of patients having skin to skin during their C-sections. You can see it's fine to operate around them. And look how much happier they are. Okay, so which patients are candidates for these types of choices in the operating room? Generally speaking, most patients can be offered some of these choices, if not all. Some may not be able to get skin to skin, but they could certainly watch the birth, for example. For patients under 36 weeks, I chat with NICU about this. I also chat with the birthing parent and their support people, because it's not uncommon for babies to get secondary apnea where they come out looking great and then not. So I just make sure we're all on board with knowledge and awareness and plan. For patients with medical conditions, or if their baby has a medical condition, I talk to NICU. Patients' body habitus sometimes is a problem. This could be a large abdomen or pendulous breaths or severe obesity, making it hard to deliver the baby up to their chest. So I review about that and the possibility of not being able to, even if we want to. If the patient's having multiples, I discuss the logistics of this with the patient and with the NICU team. I've had twin moms elect to hold both babies. I've had others where they wanted one and they wanted their partner to hold the other. Sometimes directly skin to skin, sometimes swaddled. Again, it's just about offering those choices. What about patients who are in labor? Absolutely. Unless it's an emergency for, fetal heart tones or a cord prolapse or something, there's no reason why you can't have these or offer these birth choices with them. And then what about chorioamnionitis where they're infected? Probably not. That baby might be best served in the warmer first. These birth choices are really no big deal for us. Dropping that drape, delivering the baby up to their chest, removing my sleeves, changing the gloves, and singing happy birthday in reality all adds like 1 or 2 more minutes to the case. But these choices make a major life-altering experience for the patient. This is the original patient in the story. That's me on the left and my old partner on the right, shared with permission, of course. She had 5 other C-sections where 0 choices were given to her. She and her husband are both ICU nurses, and she cried in my clinic when I offered these choices to her. This delivery was 7 years ago, and when I reached out to her a while back about sharing this photo and her story, she is still over the moon to hear that I will be sharing this process and delivery experience with others. So just consider the impact you all can make by changing really minor things in the workflow. That is the end of the cases. So I will just summarize with some quick pro tips, and then I'd be happy to tackle any questions. Trauma-informed care works when you use the universal precautions model. So apply this to everybody. Assume everyone you interact with, including your patients, but also your fellow colleagues, has a trauma history. And remember to shift your thinking from what is wrong with you to the more non-judgmental, what happened to you? Explain all recommended exams, interventions, and even expectations during interactions in detail so the patient knows what to expect and what is coming next. Check in frequently with them. A simple, are you doing okay during an exam, or do you need a pause during an interaction, can feel empowering to the patient, and so does offering them choices whenever possible. Consent your patients in everything you do. Never assume consent. When you're sharing information with patients, be as honest, transparent, and non-judgmental as possible. And be intentional with this in all of your interactions. Remember to always strive to know more and get better at what you do. While you are the expert in your field, the patient is the expert in their own life. We should strive to always be looking for ways to make our interactions feel more safe, more welcoming, and more empowering for our patients and also for each other. That is the end. This is the QR code for HCET and MTITC, the Midwest Trauma Informed Training Center. If you would like to sign up, and that email, you can email them and you'll be on their the list to get the listserv, it's called, to get all of the updates and future webinar introductions. I'm happy to take any questions.
Thank you so much, Dr. Conklin. That was awesome. We've got a couple things going on. We've got Jen dropping the evaluation link in the chat, and we have a question in the Q&A. So Hattie asks, the family-centered C-section modality feels like a major TIC model to incorporate in practices and labor and delivery teams. Do you have material or offer consultations for implementing these protocols?
Yes, I do have materials. I have a whole workflow typed up similar to what I shared on those slides. It's a lot of effort and just slow, gentle pressure to get it to change. For example, in my private practice in Michigan, where we were only one of 2 delivering practices, it took about 2 years to get it fully implemented. People are very used to, all of us, admit it or not, are very used to our workflows. I first started kind of cruising around this idea in 2012 when I was having to do a C-section on a midwife patient, and she was very frustrated that she couldn't really participate in any of her birth. And I dove down a pretty significant rabbit hole, but it's been evolving ever since. I'm always changing things. I'm never done doing things in all of my trauma-informed practice, not just surgically speaking. And that's an important point I want to drive home. Like, this is not something you just get to. It's not a destination where you're just done. You're constantly trying to do better by patients. So I'm always modifying things. And so I do have a list. I do have a workflow. I'm happy to do consulting, but it really does take a couple of really passionate advocates, and I would advocate for having them all be sort of different levels of care as well. So like having labor and delivery nurses and pediatric or NICU nurses and somebody from anesthesia and obstetricians really need to be involved as a group, because if it's just one person, it makes it so much harder, right? We have a couple of anesthesia people that are very, very passionate about trauma-informed care, and a couple of NICU nurses love this. And in Michigan, as we started evolving this, and then the NICU nurses and the labor and delivery nurses themselves needed C-sections, they were asking for this workflow. And if you're asking for this for yourself, you should 100% be advocating it for patients, right? Treat everybody the way you'd want to be treated. So yes, I do have workflows. Is a long answer to say, yes, I have a workflow typed up. I'm happy to do consulting with folks to, I have presentations I can give folks to see how this works. I have videos that have been done for this. Happy to help out. Would love to spread this everywhere.
Awesome. Thank you. Any other questions? Or while we have a relatively quiet group, any other gems, pearls, or points you want to make, Dr. Conklin?
I don't have anything specific, just that going back to, this is a constantly evolving thing. I changed the way I do things even recently. Like, I used to do thyroid exams from behind the patient, and I'd warn them, I'm going to reach around your neck and feel the front of your neck. But I had a medical student 2 years ago point out that's not very trauma informed. And you're right? If somebody's had a history where they've been strangled before, which most people are not going to just verbalize that to you, even though I warn them, that can still be very triggering to be touched that way. So I quit doing that. I do the thyroid exam from the front. So it's just about constant awareness and listening to patients. Every time a patient makes a statement to me where I hadn't thought about that before, there have got to be countless patients that have thought it and never said anything. For example, my most recent change is when I used to educate people about annual exams and putting their gown on, I would encourage them to put it open in the back because that seems the most dignified to me and the patient is the most covered. But then I've had patients say it's harder for them to get the arm out of the gown to do the breast exam. So now I explain you can have it open in the front or the back, and I explain exactly how the breast would be exposed in both scenarios. And that gives them the choice then to decide how they want to put their gown. So it's just about paying attention to the way patients are experiencing your interaction and being willing to modify the way you do it, even though change is super hard for me. I hate change. It's probably hard for most of us in healthcare, but it's just about being willing to do that, right? To step into that uncomfortable space to see if you're making a difference for folks.
Thank you. And we've got some big appreciation coming in around your thoughtful presentation, inclusive examples, and awareness. And we have one more question, which is from someone whose team involves a lot of new RN graduates for whom trauma-informed care is not yet incorporated into their RN education, which we hope to fight to change. But while orienting them to the unit, do you recommend providing feedback and trauma-informed care direction to these team members?
Yeah, absolutely. HCET and the MTITC websites have tons of accessible, including this presentation, which will eventually end up there. Tons of accessible presentations on this stuff. I'd be happy to sit down with anyone to go over like sort of highest yield access. So, it's very difficult to go through orientation as any person, a physician, a nurse, whoever. So the highest yield information that you could provide them would be great. But one of the greatest ways to teach new people is to like an apprenticeship, right? You practice what you preach. You do it and have them model the way they do it from you. So you go in and talk to a patient so they can see, hey, we need to do a cervical exam, and this is what to expect during the cervical exam, and this is what's going to be covered and uncovered, and do you have any questions about that? Is a great model for them to learn. Just watching, do as I do, and learning that way is a great way to approach it.
Cool. Thank you. People giving love to the family-centered care in the chat. And the Q&A has been quiet for a few minutes. I'll give another slow pause to give people one more chance to enter anything that they have.
I didn't share my email, but I am happy. I'll put it in the chat. I am happy to take questions privately if people would prefer that instead. It says to hosts and panelists. I don't know if you can share that, Kara. Maybe I can't give it to everyone. anyway, if you don't want to share questions in the chat or in the Q&A and you want to reach out to me privately, happy to take that.
Okay. Well, please complete your evaluation. Reminder that you'll get that email if you need nursing contact hours. And huge thank you to Dr. Conklin and to all of you for joining us. Before we close out, this QR code on the screen right now is how you can sign up for the Midwest Trauma Informed Training Center's newsletters and updates and all those fun things. So please feel free to get on our list for future educational offerings like this. Or if you prefer, you can email updates@hcet.org. Thank you so much for spending your lunch hour with us. We appreciate you.
Thanks, guys.